being recorded, and we will post the recording on the nursing home social work resource page within 24 hours. So if you aren't able to stay for the whole session today, please know that it'll be available online free of charge to anybody who clicks on it. This is Mercedes Byrne-Klug from the University of Iowa in Iowa City, Iowa, and I'm here to welcome you to our next webinar geared toward nursing home social workers and social service staff members. And to start out our presentation today, I'd like to hand the recording over to Deirdre, who is going to introduce our speakers. I should let folks know that everybody other than a speaker is muted, and at the end of the session, when there's question and answers, you put your hand up cyberly, and then I'll unmute you if you have a question, or you can feel free to type your question in the chat at any time. So I'm going to turn it over to Deirdre. Thank you.
Thank you. I'm happy to introduce 3 speakers we have from the Abramson Center from the Marilyn and Leonard Abramson Center for Jewish Life. They're located in the suburbs of Philadelphia, and they're going to be speaking with us about work they have done on enhancing quality of life through understanding depression and careful monitoring. Our speakers are Dr. Scott Crespy. He is the Vice President for Quality Improvement. Check out his photos there. He was the principal investigator of a successful depression collaborative with 40 nursing homes across the Commonwealth of Pennsylvania. Dr. Van Haitsma is the Vice President for Research at the center, and her role was the Director of Evaluation for the study. She is also currently the editor of the Practice Concept section of the Gerontologist. Our third speaker is Marilyn Fraizer. She's the Director of Social Services at the center, and in her role, she leads the department in coordinating care of mental health of residents and supporting with adjustments to moving into a facility and case management and advocacy. And so you can see from our group, we have a nice combination of practice and research combined. So welcome, and thank the 3 of you for joining us.
Well, I'm going to kick it off. Thank you for having us. We're excited to be here and share some of our findings with you. Next slide, please. We understand that many of you were on recent webinars on the topic of depression, so we're not going to talk about the prevalence of depression or the clinical diagnosis of it, but rather we're going to start out with a common sense approach, and maybe we'll call it the grandmotherly approach to helping a person become unstuck with depression. And if you were to ask your grandmother or your friend, take off your clinical hats and think about the advice, the timeless advice people have been given over the years. If they had a loved one or a friend who was depressed, often we would hear things like, well, what did you used to enjoy doing? Why don't you go out and get outside and get some fresh air, get back to doing the things you used to enjoy? When was the last time you talked to one of your friends? Give your friend a call. Those types of advice. I think what we did was we put it into a system, and but essentially those are some of the key items. And to give you a little clearer picture of it, I'm going to ask Dr. Van Haitsma to describe our pyramid.
Okay. Next slide, please. Yeah. So. We all know that there's been several decades now of research in looking at how people get depressed and what helps them become undepressed. And so we didn't want to reinvent the wheel when we were looking at how to approach depression management within our own facility. So we wanted to take the best of what was out there from every discipline's perspective, wrap it all into one package, and then put it in the hands of an interdisciplinary team that was led by the social worker. So when you hear us talking about this program, the social worker is really the person who directs, manages, keeps it all together, and keeps the program running throughout. So we're very happy to present to all of you who serve such a central role in the mental health treatment of our frail elders living in nursing homes. The pyramid that you see here really is a picture of how we thought about the causes of depression and who is typically involved in the treatment of depression across the spectrum. So most depression programs begin at the top with the mental health professionals, psychology, nurse practitioner, psychiatry, who will consult within the nursing home if a person needs depression treatment. But we wanted to see if there was a way, of course, that we could draw the whole team into this, and also with an eye toward preventing depressive symptoms from getting any worse. So as you go down to the next level, which you see social work, level 2, you'll see social work, chaplaincy service, and family involvement. This is our level where we know that depression, some folks' depression is related to adjustment issues, to grief and bereavement issues, or other issues related to, their social milieu. And those team members are really responsible for what we call the level 2 causes of depression. Going down another level, recreation is primary, along with restorative care, in terms of looking at people who are depressed because of well-known theories related to Lewinson's hypothesis that people who become depressed spiral downward in their depression because they become more isolated, they're anhedonic, they become more apathetic, they are not involved in being behaviorally active in the way that they were when they were not depressed. And so the treatment plan is then to provide behavioral activation. So this whole we'll talk a little bit more about how we built the toolkit, which I think did we give that to them? Yeah, so you have the toolkit there, and you'll see these 3 levels reflected in the toolkit that represents the best practices that we pulled from the literature. We didn't make anything up. We simply put it together in this way to help staff as they were thinking about how to treat a given individual in the nursing home, a starting point for initiating treatment.
Okay, next slide. So back in 2007, we wanted to test these ideas about how would administering these various levels of interventions, starting with level 1 in uncomplicated situations, uncomplicated meaning like an absence of psychotic symptoms or suicidal ideation. And within a course of a year, we surveyed, administered a depression screener to, I think, about 360 residents. And of those, we had 67 of those in the depression screening that screened positive, and 50, as you see here, were female, 17 male, and initially there were 80 residents, 67 were in long enough to be rescreened, and we had 2/3 of them showed some improvement, and that was just, it could have been a 1-point improvement. Next slide. And nearly 42% experienced what we would call significant improvement, going from a positive depression screening to a negative depression screening, and with similar results for the males and females. Next slide. And for those of you who've been in the industry for over 2 years, you'll remember the MDS 2.0 and the 4 quality measures that were related to either depression or behaviors. And we were happy to find that putting a quality improvement system, a process into place, was able to not only maintain gains, but continue to bring gains over the course of a 3-year period. The red bars is the baseline measurement, and the blue bars would be the active phase of the study. And 2 out of the 4 were depression specific. If you remember those, prevalence of residents who had become more depressed or anxious, and as well as depression without an antidepressant medication. Next slide. But whenever you do research, I think it's true that you never really know for sure what you're going to find, and that's exactly what happened in this case. We put together the levels, and we were really shocked to find that about 2/3 of those residents who experienced the significant depressive symptom reduction had the level 1 intervention only. And if you remember, those were the interventions based on behavioral activation with the purpose of getting people moving, going, restorative nursing, exercise, and formal activities. Next slide.
So we were very pleased with the results of our pilot in our single nursing home, which we have 324 beds here. And we decided to really take it on the road and to say, you know, we're going to be formalize what we've learned in these 3 years of doing the program. And we put an invitation out to the providers in both the for-profit, not-for-profit, and the government home and hospital homes. And we're able to recruit a significant number of people. We were initially thinking that, well, you know, we'll recruit 30 homes, and, you know, we'll be lucky if we get that. This is me speaking as the researcher. I was like, oh my goodness, we're never going to get enough people to really be interested in such a topic as depression. But lo and behold, I was completely wrong. And in fact, we had such a outpouring from the facilities in Pennsylvania that we had to cut off recruitment at 40 facilities because that's all that we could handle in the project. So basically what we did is we rolled this out as a randomized clinical trial, and we did a wait list control. So people were in phase 1 were assigned to immediately go into the treatment condition, and we had our wait lists just do business as usual, also collecting data, and then we phased them in 4 months later. And then we continued to do data collection with these facilities for 8 months following that. So we really wanted to see whether the program that we had developed in this single site was able to be exported and replicated in nursing homes all across Pennsylvania. Next slide. And if you're interested in reading more about the particulars of our internal program, you can look at this particular Provider Magazine article. Do we have the reference, or do we send it to them?
We included it in the toolkit.
It's included. And we are in the process of writing up the results of the randomized clinical trial, but we're going to give you a little preview right here in terms of the outcome of that, those efforts. Next slide, please.
Okay, so you know a fair amount about the PHQ-9, and one of the differences that we did was we postulated that having a prevention focus would be beneficial. So the Medicare's quality indicator looks at residents or triggers for residents who have scores in the 10 and above or moderate to severe range. We decided we wanted to include people with scores 5 to 9 in the mild range, with the idea being if we catch residents at earlier stages, it would be both easier to address it and also hopefully prevent them from becoming more depressed. Next slide. So our intervention levels have 3 major focuses. I mentioned the prevention focus, focusing on those residents with scores of 5 through 9. The interventions had a stepwise approach. As long as there wasn't complicating features, we figured it would be beneficial to start with behavioral activation level 1 for an adequate duration and also an adequate intensity. And my researcher friend here has always challenged us in terms of intervention fidelity to better describe that. We kept that kind of loose, meaning as roughly speaking, we tried to, since we meet on a 6-week basis to discuss residents, that we were on average giving an intervention approximately 6 weeks to see if it was having an effect before moving to the next intervention, either within that level or adding another level at the next time. And as Kimberly mentioned, we encouraged people to use their discipline's best practices. Next slide. So level 1, just quickly, next slide please. We're finding that depressive symptoms of a lack of interest or pleasure, sometimes referred to as anhedonia, and or apathy, are sometimes symptoms that could be key or signal that behavioral activation might be a useful approach. Here are some basic principles of behavioral activation. The one thing we did tweak a bit was and it's in your toolkit, for restorative nursing, while our nurses, they're wonderfully have terrific approaches with residents in general, we thought it wouldn't hurt for them to have some specific depression-specific approaches to consider. And some of these are sort of mentioned here. You know, start with what people like, start with easiest tasks first, and monitor and reinforce success. Next stage. Next slide. And we rely heavily on our CTRSs here, but because we feel they add quite a bit in terms of addressing those depressive symptoms. Next slide. What's the password? You got locked in. Okay. We know where we are.
Okay. Greetings. Wanted to talk with you about level 2 at this point. in level 2, the social worker focuses on supporting resident well-being. We look to normal social support. We look back with the resident about their lives, their coping strategies in the past, how they have managed before. We spend one-on-one time enhancing those healthy coping strategies, utilizing a focus on the resident's strengths and rallying social supports through any loss or of ability, loss of loved ones, and certainly, you know, with the whole issue of living in facility. To the extent that it is helpful, we certainly reach out to families, peers, new friends, old friends that the resident may relate to. Staff members are key. The whole team is of value to the mood, stability of the older adult. And I spoke a little bit about easing the adjustment as well. So those are the certainly the focuses of the goals of level 2. The social worker is one of the main resources. This is the discipline that takes the lead on this level, and chaplaincy as well. We partner together to help residents reach out beyond themselves, again, in their new community. One thing I would say here, and I think most of the social workers in the room that work in long-term care would heartily concur, is that the ability for the social worker to reach out and rapport build with her or his or her team members, from housekeeping to plan operations to, of course, nursing and all the other disciplines, is really key to lay a framework for the best responses for the older adult. We have a very robust recreation program within our unique organization, but for anyone in long-term care, developing a close rapport and building that great communication that happens in the house is very, very important. I meant to switch to the next slide if we could. I was speaking about the next slide. We certainly reach out to our chaplain as well as our recreation team. Even though they're in level 1, I think Scott explained that it's kind of amorphous in a way. We are a team and we all work together at every level of intervention. So we got recent guidance, or not so recent guidance, but when we were getting some good feedback from professionals across the country, the one suggestion we got was give them everything you got at the front end. And we really take that to heart. It really proves that if we are working again as a team, the initial adjustment is
Anybody
really...
have Mercedes' cell phone number?
Yeah, I do.
Can you text her? Can you text a text message? Oh, I like those. They're cute.
Somebody's not muted.
No, she's on the...
Okay, so starting off on the right foot enhances the resident's prospects for a positive adjustment. And again, in our organization, we do have, as you probably all do, resident council, some welcoming committees. We do also use those tools in, you know, mobilizing the welcome and adjustment efforts for everyone.
Okay, next slide. we're not going to spend a lot of time on level 3. It is mental health specific services of psychology, psychiatry, and other mental health professionals. And that level 3 interventions would include the use of antidepressant medications. Next slide, please. And as Dr. Van Haitsma mentioned at the onset, that level 3 interventions are typically the industry standard and often the starting point. And there is a huge evidence base for them as well. Next slide. One of the things that we thought was, and still think, is the key driver for our depression prevention and management program is a continuous quality improvement process. Next slide. And we think that it drives a lot of what we do to help identify those residents at risk for depression and help address their issues. Next slide. And we think of it in two major ways. At the resident or patient-specific level, and also at the facility level. And most professions, professional organizations have their own system, and even our researchers use a scientific method to talk about using an iterative process, or a process in which we continually tweak, because especially dealing with people and dealing with issues such as depression, there are multiple factors that are contributing towards people's depression. So a root cause analysis is going to be a fine first start, but may not be adequate. So for the individual level, we want to make sure that our staff are trained and prepared to do the depression screening, and then they screen, refer, treat, but then we evaluate our results. We see our interventions having the impact that we want, and we modify the care plan. One of the key things about our program is that it's sort of, who was it, President Bush, that said no child left behind? Well, we sort of taken that on, meaning we will continue to have our residents in the depression program until they have a complete remission in their depressive symptoms, meaning less than 5. And sometimes that could result in talking about a person for maybe 2 years. We'll hear more about that later on. And then a facility level approach. One of the things we taught the 40 nursing homes to do was to look at their aggregate results. So not only look at how is each individual resident faring, but when we look at the percentage, and now it's easy, because you have a quality indicator that looks at it. If your depression rates are where you want them to be, terrific, but as you incorporate and start a program, you can tweak that program, and we had to ourselves. We went from meeting at every 12 weeks to every 6 weeks, because we just weren't seeing the effect that we wanted. Next slide.
So we would like to familiarize you with our wellness rounds. We're very excited about this. It's sort of the highlight of my week, if you will. The social worker facilitates this process, and preparation is really key. What happens is, based on the results of our MDS mood assessments and our behavior assessments, we are able to identify those people who are triggering, 5 and above. with a score of 5 and above. And we prepare by writing a note about those, which I think that's also a form that's included in your toolkit. We also notify, our meetings are on Friday. We notify all the other disciplines involved. The goal is by Wednesday, and thereby everybody else can do research on these people who are triggering for our Friday meeting. Now, hold your seat, because you have to hear all the wonderful players that come to this meeting every Friday. They are the social worker, the nurse, the recreation department head, our senior psychologist, our medical director, our quality improvement officer, Dr. Crespy, our dietitian, and a chaplain. This is just such a rich group of people who are all then focused to discuss the individual people who have triggered. And especially since everyone has prepared many of the times. I mean, we're not perfect. It's not perfect every time, but the more advanced notice, the richer, of course, the discussion, because people have all their own experiences and we come together. We continue to try and welcome everyone to this meeting. There is a great value in also welcoming the aide, the direct service provider, to this meeting, and we are striving to achieve that with our other requirements and needs within the household at every given point. That's a little difficult to achieve, but we are working towards that as well. So during this time, the social worker does present using the mood note on the diagnoses, anything currently that's going on for that person. Sometimes if we see someone really plummet, they may have recently gone on hospice with a significant change in their medical or functional status. But the whole person is presented, and then we kind of go round robin and discuss the needs of that person. Our medical director, we pull in the whole cart of charts and care plan books. So our medical director is quickly flipping through the charts, and we also monitor our care plans to make sure that they're on point with where we are in our discussion, so that we've got really good data, and it's a very, very good discussion. Just a little example of something that recently happened within one of these meetings. A resident was being discussed that was having a behavior, and so the plan was that recreation was going to go and talk with the resident about preferences and, what was the problem, why was she getting upset at these certain times of the day. And she explained to the recreation coordinator that, she's really upset because she's not able to do her makeup anymore, and she really likes to wear her makeup in the morning. And so what they were able to do and report at the next mood meeting was they paired two residents together that could assist each other with the makeup, and this was a partial solution to the mood issue. So we really try to be quite creative and never say die, always look to new ideas and opportunities in that regard. Next slide.
So now we're going to tell you a little bit about how we rolled this out to the 40 nursing homes. Next slide. I guess first thing I want to say is, Marilyn painted such a beautiful picture of all the disciplines that were represented. But one of the key things we talked about with the 40 nursing homes was we were not asking them to add any resources. So when they started the project, and on your screen you'll see the long-term care, the associations that helped with recruitment. Next slide. We were very specific about that they were not going to be asked to use any more resources. It really was about structuring existing resources and organizing them in such a way that they could better get their hands around their issues of depression.
Yeah, so again, this is what I had mentioned briefly, and we're running out of time, so I'm not going to spend a lot of time on describing the project, except that, you know, we did have, as I mentioned, the waitlist control, but the training modules that we're going to go through just very quickly and mention that there were actually 4 different training webinars that our facilities went through, basically to get in a lot more detail what we've just given you today. Those were the kickoff for the project, and then they went into begin using these smart Excel spreadsheet for data collection. So let's go to the next slide, please. And if you click again on the slide, you'll just see that we had quite a range of participation from urban to rural, small and large, for-profit and not-for-profit facilities. Next. And this is the tool that we used to ask them to track how well they were doing in terms of their depression symptoms, which were modeled after the National Advancing Excellence campaign. Next, please.
Can I say a little bit about this? We consider this caseload management feature of this tool. You could consider it sort of a training tool. It is a way, in every nursing home, if you ask your DON which residents have pressure sores, they could tell you it. This was sort of the social worker's equivalent of knowing who's in the depression program and how are they doing. And this could be used for as long as is needed, but and I believe we included this tool with the handouts that we provided. Next slide.
Okay, so this is, again, you have a copy of the toolkit, which describes obviously in more detail what we're skating over today. Next slide. The webinar series I mentioned, I believe were not included, but if anybody's interested, we have them recorded and would be happy to provide them to you if you're interested in listening to them. They consisted of sort of an overview learning session where the goal was to really educate all of the team members in the challenge of depression, what depression was. The learning session was depression screening and the features of the program that we just described. Next slide, please. Learning session 2 went over the quality improvement aspects, workflow, how the rounds worked, the particular role of the medical director, and how we are going to be tracking outcomes. And then we also dedicated a specific session to suicidal ideation. Next slide, please. Which we used really terrific toolkits, which is available through SAMHSA, and we had some of the speakers in this session who were involved in developing that particular toolkit for SAMHSA. All right, next slide, please. So this just gives you a sense of the process measures of the 40 facilities that participated. We had terrific attendance in the webinars. Our data submission compliance, those forms that you saw, the data tracking tools, were phenomenally compliant. Right up there you see in the 90 to 97%. So this indicated to us that people were actually using the materials and found it useful to continue to use them over the months that you see represented here. And just as a comment, the 40 homes over that 8-month period represented 22,713 assessment periods throughout the life of the project. Next slide, please. And here's our beautiful results, looking at the randomized clinical trial outcomes, the experimental versus control. We lost only two nursing homes over the course of the project. And this simply represents that the experimental folks who were involved in using this particular program had a statistically significant reduction in moderate to severe depression over the 4 months that they were in the trial. Next slide, please. And then this shows the trend that continues in that experimental group over the 8 months. So we broke randomization after 4 months, and so we only followed our experimental group over that time, but you see a nice downward trend as the depressive symptoms continue to abate. Slide, please. And again, we asked the staff who participated in the evaluation to talk to us about how well they felt that the webinar training experience went. Was the toolkit informative? How easy was the implementation of this intervention, which is, as you can hear, quite extensive to understand and implement. Next slide, please. And our results of which disciplines participated in the wellness rounds. And here you can see that social work, recreation, and nursing were the backbone of the interdisciplinary team across these 40 nursing homes, and with a sprinkling of a few people that had the luxury of having more of those disciplines represented. Okay, next slide, please. So we went through an awful lot of data. You basically got our vastly reduced education session that we took 4 webinars to do with our 40 nursing homes, but we're very, very interested in hearing any reactions or questions you might have about this program that really features the social work as the team leader in working around depression prevention and management in nursing homes.
If there's any speakers, any questions from participants, please feel free to raise your hand and I'll unmute you. Or you go ahead and type your question in the chat box. I don't see any hands up. Let me check the chat box a little bit better. Where do you get the toolkit? There's one question that's asking about that. The toolkit is on the nursing home resource website that is accompanied by our listserv, and also you can get it from our speakers at the Abramson Center. Anything else you want to say about the toolkit? Any of our speakers?
Well, it's the actual toolkit that was used in the collaborative. Since then, we've been accumulating ideas of how it could be refined, but we did have a technical expert panel of representing 8 different disciplines review it, and they had a favorable, very favorable overall, comments, and we're hoping to fold in their feedback as well down the line.
There's another question about what were the most common areas triggered on the PHQ-9?
The most common questions that triggered it, do you mean? I'm not sure I understand the question.
It's in the chat box, so I assume that's probably what were the most common items on the PHQ-9 that triggered.
Okay, that's actually not coming up for us, but did you want to just give an impression, Marilyn?
Yeah, I don't think that there were any that stood out. I mean, feeling tired, feeling depressed, I'm thinking about the questionnaire. You know, slow movement, lack of concentration, those would be the more typical positive, you know, that would lead you to know that they were triggering. It wasn't very often about appetite in my recollection, but those would be unique to, I think, your population. And I do hesitate actually to say that there's a trend in what people are answering yes to. I think it's pretty individual.
And from the collaborative, we didn't actually collect that information, so we only had aggregate results from the summary scores. So I would agree with Marilyn. What does happen at our center, at least, is we do give the depression severity score, I think it's called the total severity score in the MDS, and we try to also always have the most recent score as well from the previous quarter, because it really helps us understand the context. And for instance, a score of 10, which would be considered moderate levels of depressive symptoms, would mean one thing if their previous score was a 3, and it would mean a very different thing if their previous score was a 20. And the other thing that tends to happen is the social workers, in addition to talking about the total severity score, they talk about the individual items that triggered. And I think those symptoms are helpful in each of the various disciplines that are represented. Because I know, for instance, like therapeutic rec, they hone in on a lack of interest or pleasure. They feel like that's something they could really attack. And then, you know, dietary may look at that appetite to know whether, you know, are they really offering items that are you know, enjoyable to them, or is it a symptom of depression?
You know, I would also add, this is Marilyn Fraizer again speaking, that of course if we have somebody that is really demonstrating some, you know, serious, or to us, moderate numbers are serious. But anytime we have somebody that's really demonstrating depression or behaviors, we get on it right away, typically. We don't wait for mood and behavior to take an immediate action, obviously, as you wouldn't either. But it's a wonderful support, and it's a wonderful follow-up, because we're assessing in real time, and then by the time we get around to that household with the wellness round, it may be a couple weeks later. So it's a really great follow-through, if not the best intervention to date. We've marshaled our forces beforehand, but it's a wonderful follow-through as well.
I have a question for you, and this is Deirdre. What advice would you give to other social workers in trying to establish the kind of buy-in that it seems you've done so well? You know, given in pressure ulcer, there's immediate buy-in.
Well, I think the way this program was framed so that it would be a part of what you already do in a way, but just more effective than what you've done before. I think that probably is the largest thing. The extent to which the leadership, the administration, endorses any kind of movement toward quality of this nature is also really key. And, I mean, to the extent that an administrator would guide the other disciplines to be equally invested in and involved, that really supports the social worker. Everyone knows that social workers in long-term care, we wear a million hats. And, you know, clinical stuff is kind of what we got into the business for. And the other stuff like missing items investigations and storage and dispositions of resident belongings, I mean, those things are, you know, what we must do, but that's not what we love to do. So I think if this can be efficient and meaningful and has tremendous buy-in from the top and other disciplines, then the likelihood is that it will really start to be something to look forward to as we do these wellness rounds and the whole process.
Thank you.
There was another question on the chat, and I see that most people are chatting to me privately, so I'll read them to you. How many of the 40 nursing facilities continued with your process after the end of your study?
That is a terrific question, and this was a non-funded study, believe it or not.
Wow.
Everybody that got involved, they added it onto their already existing responsibilities. So it was, so it's a terrific question. We haven't really followed up, but you know, from our own experience, having that wellness rounds, that process in which we have a system for reviewing on an ongoing basis our residents with depressive symptoms and keeping an eye on our quality indicator, we've been able to maintain our findings. And by giving the nursing homes that we trained those same tools and them seeing their quality indicator go down and also seeing the impact across the state, I think at least, they have, the knowledge that, if having that ongoing process could maintain the gains. So we don't know, but I'm blindly hopeful.
One of the questions that we were going to be asking folks toward the end, our participants, is, do you think something like this would work at your nursing facility? And since we have a few minutes, rather than doing it at the very end, I'm going to just put that question out there right now. Any responses from participants? Do you think this kind of a program could work in your nursing home? Why or why not? Somebody wrote in that they have some concerns about how to get other people on board with it.
Yeah, I'd start with ask for a meeting with your administrator or your quality improvement officer if there is such a person in your midst. We're fortunate here because this is an environment where improvement is really desired and it's really valued. Anybody with a good idea is really given a full ear. So cultivate that. I mean, it really doesn't take more than one enthusiastic, well-informed person. And that's what I've always believed. And, you create your environment by what you bring, especially if you have this study and maybe other references that could demonstrate that this attention would really make a difference.
Also, I've loaded the tracking tool up here just to give you an idea of what it looks like. We're not going to have time to go through it all right now, but it is loaded on the website, and so you can take it and read it at your leisure and also share it with your colleagues. And then, as our panelists mentioned, also they have 3 webinars that they've recorded that kind of could walk you and your staff through how to use this information and how to understand their level system, and then how other team members would be involved. So this is a little bit about what that tracking tool looks like. I'm going to open up the public report just to give you an idea, and until I see some more questions coming in, just to show you what kind of information is also available. So you could download the report and share it with your staff or share it with your administrator, because they've summarized some of their findings and what their goal was. I don't see any other questions. Panelists, anything else you'd like to share, or what other kinds of questions do you typically get when you present this information?
I could just build off that last question about how do you get buy-in. One observation that I've made, at least at our facility, is that I see a kind of professional pride among the clinicians, the employees that attend our mood and behavior rounds, and they come prepared. Their knowledge, their experience, their training is appreciated, respected. So it's easy in I think our industry to try to stay above water, but it's an opportunity for people to feel, I think, really good about their contribution and have it be respected among their peers.
I would just also add that it's really within the last year or so that we've gotten really, really regular participation by chaplaincy and our dietary department. And it's interesting because it's as if kind of this is the happening thing, and you want to be a part of it if you're, I can't, and it's really, really been enriched by those disciplines heartily. So, it's interesting how it's even changed and been enhanced here, where it's been an established practice for a period of time.
And I would also, building on what Marilyn said, I think social workers probably feel they have the weight of the world on their shoulders in terms of the mental health of the residents. And how amazing is it to have members of the different disciplines support the mental health of your residents, so that the social worker, not only are they respected for their clinical skills, but they're, pardon the sports analogy, that they're also the quarterback of a team, and they have a team of people helping them, so they're not going about it themselves. I think that has to help with the burden of the stress of the job.
And the solutions or the interventions, I will say, are more unique and creative when all those different disciplines are represented. And as the social worker sets the tone of respect and appreciation and inquiry and curiosity about what other strategies might be employed, the social worker can lead that that consciousness, that climate within any interdisciplinary group.
This is Merce. I really liked your figure with the pyramid on it, and I think that alone could be used to stimulate a discussion within any nursing home in the country about what the different disciplines are there to do on behalf of residents, because this is really about quality of life. And so even just getting the conversation started by how does your facility understand the purpose of activities, the purpose of social work, and then your chaplaincy services or a consult with chaplaincy. I think it could be really interesting to have this kind of discussion within each facility to sort of, first of all, find out, is everybody on the same page? I mean, do people agree on how depression or assessing of depression or doing treatment planning for depression or suspected depression is handled at their facility? So that figure alone, I just think, could really stimulate a very meaningful and important conversation.
That's great. Thank you.
Well, I want to thank you very much for your time. What an exciting project, and that all those 40 nursing homes in Pennsylvania waited for their turn to get some of the information so that they could start doing this. It looks so exciting at the individual level and also at the facility level. And another thing that could keep the staff interested is sharing the results from families' perspective and from the residents' perspective too, when people start noticing that residents are looking more engaged or acting more engaged. Go ahead and give that feedback to the rest of the staff. Thank you, everybody, for your time and attention. Tomorrow, this session recording will be posted, and then tomorrow also we'll put the information up about next week's webinar, which will be done by Robin Boniface and is about behaviors. Thank you very much, and this webinar is officially concluded. Bye-bye.